Welcome. I hope your day is going great. We are going to be discussing pharmacodynamics. This seems to be, again, a little bit more dry material, so you may need another cup of coffee. Pharmacokinetics refers to the movement of the drug through the body and how the body affects the drug through the processes of absorption, distribution, and elimination. And elimination includes metabolism and excretion. Pharmacodynamics refers to how the drug affects the body, how the drug initiates its therapeutic or toxic effect at the cellular level and systemically. This figure demonstrates the relationship between pharmacokinetics and pharmacodynamics. Once the drug reaches the site of action, the drug effect is produced, which is pharmacodynamics. The relationship between the size of an administered dose and the intensity of the response produced determines what is the minimum and maximum amount of the drug to be used and how much to increase the dose to produce the desired increase in response. Drugs are able to increase their effect, but only up to a point, and then the effect remains the same even when the dose is increased. The figure on the right shows the basic components of the dose-response curve. During phase 1, the curve is relatively flat. Doses are too low to elicit a significant response. During phase 2, the curve climbs upward as bigger doses elicit correspondingly bigger responses. Finally, in phase 3, the curve levels off. Larger doses are unable to produce a further increase in its effect. Maximal efficacy and relative potency properties of drugs are demonstrated in dose-response curves. They are different. Maximal efficacy is the largest effect that a drug can produce, as demonstrated by the height of the curve. The idea is to match the intensity of the response with the patient's need. The goal is not necessarily to reach maximal efficacy. In the graph on the right, merperidine has greater efficacy than penazocine. Efficacy is an important quality in a drug. Potency of a drug refers to the amount that must be given to cause an effect. It really doesn't mean much when comparing drugs. For instance, the picture on the right shows that 10 milligrams of morphine equals 100 milligrams of merperidine. In this example, achieving pain relief with merperidine requires higher doses than with morphine. We would say that morphine is more potent than merperidine. Note that if administered in sufficiently high doses, merperidine can produce just as much pain relief as morphine. Potency is not related to efficacy. Drugs often work by binding to a receptor. A receptor is any functional macromolecule in a cell to which a drug binds to produce its effects. It's generally proteins. Technically, receptors can include enzymes, ribosomes, and tubulin. Receptors are found in the cell membrane, in the cytoplasm, and in the nucleus. Anything that binds to a receptor is called a ligand. Once a ligand binds to a receptor, stuff happens. The binding of a drug to its receptor is usually reversible. Receptor activity is regulated by endogenous compounds such as norepinephrine in this diagram. When a drug binds to a receptor, it will mimic or block the action of the endogenous regulatory molecules and increase or decrease the rate of physiologic activity normally controlled by that receptor. For this example, under physiologic conditions, cardiac output can be increased by the binding of norepinephrine to the receptors on the heart. Norepinephrine is supplied to these receptors by nerves. These same receptors can be acted on by drugs, which can mimic the actions of endogenous norepinephrine and thereby increase the cardiac output or block the actions of endogenous norepinephrine and thereby reduce cardiac output. These are important properties of receptors so you can understand their role in pharmacodynamics. Receptors are normal points of control of physiologic processes and are regulated by molecules supplied by the body. Drugs can only mimic or block the body's own regulatory molecules and cannot give cells new functions. Drugs produce their therapeutic effects by helping the body use its pre-existing capabilities. Again, it cannot give cells new functions. In theory, it should be possible to synthesize drugs that can alter the rate of any biologic process for which receptors exist. Thus, many more drugs are potentially on the horizon. The more selective a drug is, the fewer side effects it will produce. Receptors make selectivity possible. Each type of receptor participates in the regulation of just a few processes. Agonists are molecules that activate receptors. Because neurotransmitters, hormones, and other endogenous regulators activate the receptors to which they bind, all of these compounds are considered agonists. When drugs act as agonists, they simply bind to receptors and mimic the actions of the body's own regulatory molecules. Another example, in addition to dobutamine, is albuterol, that when inhaled dilates the bronchi and is an agonist. Antagonists produce their effects by preventing receptor activation by endogenous regulatory molecules and drugs. Antagonists have virtually no effects of their own on receptor function. Although antagonists do not cause receptor activation, they most certainly do produce pharmacological effects. Antagonists produce their effects by preventing the activation of receptors by endogenous regulatory molecules. Non-competitive antagonists bind irreversibly to receptors. The effect of irreversible binding is equivalent to reducing the total number of receptors available for activation by an agonist. The result isn't permanent, as cells delete and create new receptors all of the time, depending on the needs of the cell. The figure on the right demonstrates the binding of phenoxybenzamine, which is used to treat a pheochromocytoma, which is a tumor of the adrenal gland, blocking norepinephrine. The norepinephrine does not have as great of an effect due to the decrease in the number of available receptors. Likewise, omeprazole irreversibly blocks the hydrogen-potassium ATPase enzyme at the receptor in the final stages of acid production. Competitive antagonists bind reversibly to receptors. Competitive antagonists produce receptor blockade by competing with agonists for receptor binding. If an agonist and a competitive antagonist have equal affinity for a particular receptor, then the receptor will be occupied by whichever agent, the agonist or antagonist, is present in the highest concentration. Looking at the graph on the right, it is showing isoproterenol as the agonist and propranolol as the antagonist. The propranolol binds reversibly to the same receptor site as the agonist. Because they bind reversibly and compete for the same binding site, their inhibitory effects can be surmounted by addition of a higher concentration of agonist. The effect produces a rightward parallel shift of the dose response for the agonist towards a higher concentration. In the presence of a competitive antagonist, agonists can still produce the same maximal effect as in the absence of an antagonist, the only difference being that the higher agonist concentrations are needed to produce the same level of effect. Note that the maximal response achievable with the agonist is not reduced. Competitive antagonists simply increase the amount of agonist required to produce any given intensity of response. The vast majority of clinically used drugs that act as receptor antagonists are competitive antagonists. Partial agonists are agonists that produce less than a full response when they fully occupy their receptors. In contrast, full agonists produce a full or maximal response. Clinically used examples of partial agonists include aripiprazole, which is Abilify. It's a dopamine partial agonist used in the treatment of schizophrenia. Schizophrenia is a condition with both excess dopamine activity in one area of the brain, resulting in hallucinations and delusions, as well as a coexisting reduced dopamine activity in another area, causing cognitive impairment. Abilify, or aripiprazole, is thought to produce beneficial effects in schizophrenia by exerting agonist effects in the areas of dopamine deficit, while exerting sufficient antagonist effects in areas of dopamine hyperactivity. Buprenorphine, which is Suboxone, is an opioid partial agonist that produces significant analgesic effects to produce pain relief by stimulating opioid receptors, yet has a much lower risk for producing life-threatening respiratory depression as compared to a full agonist such as morphine in situations of drug overdose and or opioid abuse. As stated previously, receptors are dynamic cell components. The number of receptors on the cell surface and the sensitivity to agonists can change in response to continuous exposure to the agonist causes the cell to become desensitized or refractory to the agonist. Several mechanisms may be responsible, including destruction of receptors by the cell and modification of receptors such that they respond less fully. Continuous exposure to an antagonist has the opposite effect of tolerance. The cell is said to become hypersensitive or supersensitive. This occurs because the cell synthesizes more receptors. Therefore, there are a greater number of receptors at the cell surface and the response increases. Not all drugs require receptors to work. The pharmacologic effects of antacids, antiseptics, saline laxatives, and chelating agents are the result of simple physical or chemical interactions and not interactions with cellular receptors. The dose required to produce a therapeutic response can vary substantially among patients. The measurement of interpatient variability produces a bell curve. The ED50 is the dose that produces a response in 50% of the population. The initial dose of a drug is necessarily an approximation. Subsequent doses must be fine-tuned based on the patient's response. The ED50 in a patient may need to be increased or decreased after the patient response is evaluated. If you think of the bell curve, these clinical implications only make sense. Underpinning the treatment process is the intricate relationship between the body and the medications. Practitioners must be aware of the effect of pharmacokinetics and pharmacodynamics when prescribing drug therapy for patients. We will be talking about drug-drug interactions more specifically in the cytochrome P450 lecture.